Welcome to this installment. I'm Pennan from the California MDR TB Consult Service, and I'm going to be talking about multidrug-resistant tuberculosis epidemiology. My objectives for this talk are to describe the national and global epidemiology of MDR TB so that we can recognize who is at higher risk for MDR TB. Let me go over some brief terminology I'll be using in this talk. First, monoresistant TB is TB that's resistant to just one drug. MDR TB is TB that's resistant to at least INH and rifampin. A couple of subsets of MDR TB that I won't be talking too much about today but might be useful for you to know are pre-XDR TB, that's MDR TB with additional resistance to a fluoroquinolone or a second-line injectable drug, and XDR TB, which is MDR TB with resistance to a fluoroquinolone and at least one second-line injectable drug. Globally, WHO recommends or estimates that in 2018 there were almost 500,000 incident cases of MDR TB, with about half of those cases coming from India, China, and Russia. Keep in mind, surveillance does vary a bit by country and region, but it has been improving over time in general. When I display these data geographically, here you can see the percentage of new cases of TB that have MDR TB, and the overall global average is 3.4% of cases with MDR TB. You can see on the map, though, that it's not distributed evenly, and the highest rates, more than 25%, occur in the former Soviet republics, with some other countries having relatively high rates in Asia and parts of Africa and South America. If I add in the percent of previously treated cases with MDR TB, you can see that the proportion goes up. So globally, overall, the proportion of cases previously treated for TB with MDR TB is 18%. And again, the highest rates, more than 50%, are in the former Soviet republics. Now, switching gears to showing some US data, this graph shows the percent of new cases that have INH resistance in the green and MDR TB in the blue. Now, a couple of things to take from this graph. One is that INH resistance seems to be slowly increasing, but has been between 8 and 10% during this time period. Whereas MDR TB has been stable really for more than 15 years at 1 to 2% of all TB cases. The other point is that INH monoresistance is much more common than multidrug-resistant TB in the United States. This graph shows MDR TB broken down by prior treatment for TB in the green bars and previous treatment for TB in the purple bars, with the percentage, again, of all cases that are MDR TB in the red. So you can see that the vast majority of MDR TB cases are in people who have no previous history of TB treatment. And again, just 1 to 2% of cases in the United States are MDR TB. So if we put some of those data together to answer the question, who is at higher risk for MDR TB, these are some commonly recognized risk factors for MDR TB. History of previous TB treatment, we've already talked about that quite a bit, is a risk factor for MDR TB, particularly if that's recent treatment. Of course, known exposure to an MDR TB case is a risk factor for MDR TB. HIV infection is also a risk factor for MDR TB, in part because of higher resistance, higher incidence of rifampin monoresistance. And keep in mind in patients that you're treating with standard 4-drug TB treatment that a poor response, usually shown by a positive culture, a culture that remains positive after 2 months of treatment, might be a indication of acquired drug resistance or MDR TB. The other category of MDR risks I've alluded to with those maps is the proportion of MDR TB by country of birth. So in this graph, you can see that this shows the proportion of TB cases that are MDR TB by country of birth. Now this graph is among cases diagnosed with TB in California between 2011 and 2018. You can see again the former Soviet republics are at the top of the list with about 14% of cases having MDR TB. You can see it goes down in order all the way down to Mexico, which has less than 1% of cases with MDR TB. I'm going to superimpose a line on the graph at 2%. That's a generally recognized threshold for determining substantial MDR TB risk. When I do that, you can see that at the bottom of the list, countries where many of our TB cases in California and the United States come, Mexico, China, Vietnam, and Philippines in particular, are below or right at that 2% threshold. In fact, those countries also have many of our MDR TB cases. So the distinction here is that the proportion of cases that are MDR is less frequent in those countries. Now, why is the 2% important? On this slide, I'm showing a selection of these countries and their data in a table. You can see at the top, former Soviet republics, the proportion of cases that are MDR TB is 14%. When you look at those other columns that I've added, the positive predictive value for a test that's 99% specific or 98% specific, like the expert MTB RIF assay, you can see that it performs quite well in when the prevalence of rifampin or MDR resistance is high, so 94%, 89% positive predictive value. But when the proportion falls to that threshold, like the Philippines at 2%, you can see the positive predictive value is getting towards 50%, or like a coin flip. And it's even lower for countries like Vietnam, United States, and Mexico. So just keep these data in mind when you are either thinking about MDR TB risks or and wanting to order a molecular test for resistance, or when you have a result and you're trying to interpret whether this is requires a clinical response. Now, the country is not the only factor. We're also thinking about the time since arrival in the United States. So on this graph, you can see in red are the proportion of MDR TB cases diagnosed at each time point since arrival in the United States. And the blue bars are cases that are not MDR. I put a line here at 4 years. Others have talked about thresholds at 2 years. But the point here is that it's more common to have MDR TB within the first few years after arrival in the United States. When I summarize this again in a table, you can see that when we look at persons from all countries except the United States, and if you break them down into cases that TB diagnosed within 4 years after arrival in the United States versus after 4 years, you can see that those arriving most recently have a proportion of MDR TB of 3.6% compared to 1.1% in those who have been in the U.S. Longer. So keep this in mind as well when you're thinking about interpreting or ordering molecular assays for drug resistance. So if we put all these data together and who is at risk for MDR TB, one are those born outside the United States who've arrived in the United States within the last 4 years. Also are those who have immigrated from or have had recent extended travel to a country with more than 2% MDR among cases from that country based on data in California or the U.S. as a whole. So currently these countries are listed here. Keep in mind that this is based on current data from California as well as the United States. So contact your local TB program for updated information. In California, a couple of other groups that have historically had higher risk of MDR TB, including Hmong refugees and persons of Tibetan origin. So last reminder here, think about those risk factors for MDR, and if you're seeing a patient who has one of those, order a rapid molecular test for resistance. In a study that we did in California reviewing cases, we found that among 42 smear-positive MDR TB cases who had an MDR risk, almost half of them did not get a rapid molecular test for drug resistance on sputum, meaning that their time to an effective TB treatment was delayed. So thank you for listening today. Here are my team here at California, in addition to other folks who have helped me put together these data. Thank you.